of the HIEM trainees. Today I'm going to present on Rashes. Rashes, I've taken the curriculums from 2021 curriculum. It has divided the dermatology chapter into basically two topics as dermatological manifestation of systemic illness and rashes. And today I'll be focusing on the cutaneous drug reactions as in the subtopics: eczema, erythroderma, infection of skin and soft tissues, necrotizing fasciitis, pruritic rashes, Stevens-Johnson syndrome, toxic shock syndrome, toxic epidermal necrolytis, and urticaria. And this was the curriculum given in 2015. It has focused mainly on erythroderma, meningococcemia, anaphylaxis, and other topics. I'd like to start with the case presentation. This was the case which came in at Doncaster Royal Infirmary before a few months. This is a 73 years female presented with the complaint of widespread rash and shivering for 3 to 4 days. She didn't have any fever. She mentioned that rash was painful, non-itchy. It started first on the right knee 4 days back and slowly spread over whole body. She was on cocodamol for pain, and but she was not on any antibiotics. She was non-allergic to penicillin, and she had a knee replacement of the right side done 2 weeks back. But she was managing okay with that. She was walking normally, mobilizing okay. With the consent from the patient, I was able to take few of the photographs of the rashes as shown in the picture. The rash, this rash was widespread. It included the trunk, it included the lower limb and upper limb. And even it included the face and the scalp. As we can see, the rash is erythematous. There is peeling off of the skin and leaving the underlying denuded skin looking as the scarred. There's another picture of the upper limb. We can see wide spread of the rash. Anyone could think of the probable diagnosis for this patient?
Like she's not under any drugs, but like one could be like these combination rashes could be like 10 or Stevens-Johnson syndrome as well.
Okay. Yes. Okay, thank you, Tilak. Yes, I forgot to mention that is a very important differential diagnosis for this patient. Other important differential diagnosis is staphylococcal scarlet skin syndrome, toxic shock syndrome, and erythroderma. But we have excluded the Stevens-Johnson as this patient didn't have involvement of the mucous membrane. You're right in that if she would have such involvement, then obviously that would have come as the #1 diagnosis. So moving on to the treatment, we started this patient IV access, blood cultures were sent, IV fluid and antibiotics were started. And for the further management, this patient was admitted to the medical unit and management was done there. So moving on, the objectives of today's learning is to discover about some common terminology in dermatology, to discuss about briefly on the skin histology, adverse drug reaction, including erythroderma, Stevens-Johnson syndrome, toxic epidermal necrolysis, urticaria, infection of soft tissue and skin, including staphylococcal scarlet skin syndrome, toxic shock syndrome, necrotizing fasciitis, and meningococcemia. Starting from common terminology, these are the terms that are commonly used in the dermatology. The flat lesions, which have normal texture, being smaller than 0.5 centimeter, are called macule. And the lesions which are larger are called patch. Indurated lesions, which are smaller or larger than 0.5, both are called plaques. Elevated lesion, these lesions are elevated in the skin than the level of the skin surface. Being solid, it is called papule, and the larger solid lesions are called nodules. Fluid-filled lesions are called vesicle and bulla. Full pus-filled lesions are called pustules of any size. Indurated lesions which have diameter more than the depth, these are called plaques. And lesion due to extravasation of blood, if it is small, it is called petechiae, and the larger lesions are called ecchymoses. As you can see in this picture, this is the test called diascopy. We are very well aware and familiar with this test. We usually use this test in A&E. with all the patient coming with the rashes. This test is used to differentiate between the blanching and non-blanching rash. As we can see in the picture A, here the glass slide has been used to put the pressure on the rash, and there is the blanching of the rash. And it is suggestive this rash is due to the vascular dilatation. Whereas in picture B, due to on application of the glass slide, there is no disappearance of the pressure, or also known as non-blanching, and it is suggestive of the extravasation of RBCs, which we can see in purpura, ecchymosis, and other kind of rashes. So briefly discussing on the histology of the skin. Skin has several layers from inner outward. It's hypodermis, dermis, and epidermis. Dermis has two layers from inward outward. It is a reticular layer and dermal papilla. And epidermis has 5 different layers, starting from the upper layer: stratum corneum, stratum lucidum, stratum granulosum, spinosum, and stratum basale. And there is the next level is dermis and hypodermis. Adverse drug reaction. WHO has defined adverse drug reaction is any noxious change which is suspected to be due to a drug. It occurs at any doses normally used in man and requires treatment or decrease in dose of the drug and requires caution in the future use of the same drug. These adverse drug reactions are usually manifest as the cutaneous reactions. NICE guidelines have classified the allergic drug reaction into 3 different categories: as immediate rapidly evolving reaction, non-immediate without systemic involvement, and non-immediate with systemic involvement. So starting from the first box, it's immediate rapidly evolving reaction. It includes anaphylaxis, urticaria, and exacerbation of asthma. Its onset is usually less than 1 hour after the exposure to the drug. Anaphylaxis, we are well aware of this term. It is a severe multi-system reaction. It is characterized by erythema, urticaria, angioedema, and hypotension or bronchospasm. And urticaria or angioedema without the systemic features. We'll discuss briefly on urticaria in coming slides. The next classification is non-immediate reaction without systemic involvement. It has fixed drug eruptions and widespread red macules or papules. We'll briefly discuss on fixed drug eruption in coming slides. And the another classification with drug allergy is non-immediate reaction with systemic involvement, which include toxic epidermal necrolysis or Stevens-Johnson syndrome, acute generalized exanthematous pustulosis, DRESS syndrome, and others. So under the heading immediate rapidly evolving reaction, which had anaphylaxis and urticaria, we are not discussing anaphylaxis, we are aware of that term. We'll briefly discuss on urticaria. Urticaria is an type 1 hypersensitivity reaction. As we can remember from our basic science, type 1 hypersensitivity reaction occurs in response to the allergen. On first exposure to the allergen, there is formation of Ig immunoglobulin, which binds with the mast cell. On the second exposure of the same antigen, there is degranulation of the mast cell and releasing large amount of the histamines and cytokines, which causes vasodilatation, edema, and this kind of rashes are observed. Describing about the urticaria, it can be classified depending on the duration and depending on the etiology. On duration, it is acute, recurrent acute, which lasts around less than 6 weeks, and the chronic urticaria lasts more than 6 weeks. Depending on the etiology, it can be classified idiopathic, physical. It could be related with the warm weather or cold weather, autoimmune, hypersensitivity, contact, inherited, and drug related. Some of the common drug which causes urticaria include aspirin and penicillin. Clinical feature of the urticaria, we can see the rashes shown in the pictures here. The rashes of the urticaria are ranges from 0.1 millimeter to 10 centimeter in size. It has deep coalescing lesions. The wheel lesions coalesce to form the bigger lesions, which with the central fading and darker on the margins. As shown in the picture, there is pale pink edematous wheels with the surrounding flares. Treatment of option for urticaria is to eliminate the triggers and to other drugs including H1 antihistamines are the first line of treatment, and other drugs include corticosteroids and S2 blockers as ranitidines. Under next heading, non-immediate reaction without systemic involvement is it includes the just a moment. The fixed drug reaction. Fixed drug reaction appears as a well-defined circular, deeply erythematous plaque, which sometimes develop as the central bulla. This is commonly seen in the lip, and glands are most frequently involving the mucocutaneous junctions. The next topic of discussion is erythroderma. Erythroderma could be due to the drug eruption, adverse drug reaction, or any other pathology with underlying skin condition as psoriasis or dermatitis and idiopathic causes. Erythroderma is a morphological diagnosis, and it is characterized by generalized erythema and scaling. Clinical presentation of erythroderma. Typically, patient present with the prodromal symptoms as fever and severing, and they have rapidly extending generalized erythema covering more than 90% of their body. And this patient has typically they have history of psoriasis or dermatitis. The complications of erythroderma is very important from any point of view, as this patient could be presenting with thermodysregulation. This patient could be in sepsis, fluid and electrolyte imbalance, and could be in cardiac output because of high cardiac output, could be in heart failure. This is one of the typical rash with erythroderma. As we can see, there is the diffuse erythematous lesion on the back of this patient, and the lesions are scaly. We can see deep erythema as described in the picture, erythroderma, diffuse scaling and erythema. For management, as this patient has ongoing thermodysregulation, we start this patient on warm IV fluid for resuscitation and balance of temperature. We start on antibiotic if there is any focal sign of infection. There is a case of erythroderma. There is a 67 years man presents with a history of psoriasis, presents with a 3-day history of malaise, oliguria, and a widespread pruritic erythematous rash, which had started on the legs before spreading to his torso and arm. He has recently been started on acitretin for psoriasis. On A&E assessment in research, the patient looks unwell and is severing uncontrollably. This airways was patent, breathing was, respiratory rate was raised with 24. His blood pressure was 70/40, heart rate was 120, CRT was 5. This patient was severely unwell. This is a typical presentation of a patient coming with erythroderma. Moving on to the other adverse drug reaction, Stevens-Johnson syndrome or toxic epidermal necrolysis. Stevens-Johnson syndrome and toxic dermal epidermolysis are considered to be the continuous spectrum of the same disease. It is an immune complex mediated hypersensitivity reaction. Stevens-Johnson syndrome is said so if there is less than 10% involvement of the body surface area. And when the body surface area is involved more than 30%, it is called toxic epidermal necrolysis. The causes of Stevens-Johnson syndrome and toxic epidermal necrolysis is either drug-induced or other causes as infection or malignancy. Common implicated drugs are anticonvulsants, sulfonamides, penicillin, and others. There are deeply, if we see the patient with Stevens-Johnson syndrome, there is deeply erythematous coalescing irregular lesions with either developed bulla or they peel off in sheet, leaving large area of a denuded skin. As we can see in this picture, there is erythematous lesion which coils together and it has peeled down. It has peeled off, leaving large area of the denuded skin. As it clear in the picture. If it is seen microscopically, there is dermis epidermis layer dissociation. In mm, Stevens-Johnson syndrome, Nikolsky sign is positive. It is a test in which when the pressure is applied over the skin, it peels off. The complications of, and more importantly, the mucous membrane is always involved in the Stevens-Johnson syndrome and toxic epidermal necrolysis. The complications of SCS and TN include infection, fluid and electrolyte imbalance, pulmonary involvement, renal failure, and sometimes late ophthalmic sequelae could be present. For the management, we must discontinue the offending agent, and we must provide the patient with supportive care, including hydration, prevention of secondary infection, export wound management, usually in the burn unit. Moving on to next discussion, it's infection of the soft tissue and skin. We'll briefly discuss on SSS, toxic shock syndrome, and necrotizing fasciitis. Starting from staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome is caused due to the infection by Staphylococcus aureus. Staphylococcus aureus produces the exotoxin, which causes separation of the outer layer of the epidermis. And it leaves large raw area resembling a severe scald, as we can see in this picture. The most of the cases of SSSS are implicated in children. However, it can occur in any age in localized or generalized form. Pathophysiology of SSSS is there is splitting in the granular layer of the epidermis, as shown in the picture. And histology of the skin biopsy, as shown in this picture, showing the epidermal detachment in the uppermost layer. And these histological findings are consistent with the staphylococcal scalded skin syndrome. What are the main differences between staphylococcal scalded skin syndrome and Stevens-Johnson syndrome? The etiology is Staphylococcus aureus infection, whereas in SCS it is drugs. The constitutional symptoms are usually absent, but in SCS it's usually present, including constitutional symptoms including fever, malaise, and others. Skin lesions are superficial peeling in staphylococcal scalded skin syndrome, whereas in SCS it's deep skin peeling lesions. Mucosal involvement is always absent in staphylococcal scalded skin syndrome, whereas it's severe in SCS. And treatment being anti-staphylococcal antibiotics, and for SCS to remove the trigger, steroid, and supportive care. Moving on to next topic, it's toxic shock syndrome. Toxic shock syndrome is an acute febrile illness. It is characterized by diffuse desquamating erythroderma. It is caused by the exotoxins from Staphylococcus aureus and in less commonly from Streptococcus pyogenes. It is associated with the menstruating woman who use tampon, but it would also be seen in other patients with burn, septic, abortion, postpartum infections, and others. How do you diagnose TSS, toxic shock syndrome? Rosens have said there must be the presence of these 4 criteria for the diagnosis of toxic shock syndrome, as the temperature of at least 38.9 degrees centigrade, hypotension with systolic blood pressure of 90 millimeter of mercury, rash, typically blanching rash, and involvement of at least 3 organ systems, including gastrointestinal, renal, and musculoskeletal system. The next topic of discussion is necrotizing fasciitis. Necrotizing fasciitis is a rapidly spreading infection of the subcutaneous tissues with characteristic widespread fascial destruction. We can see in the picture an example of necrotizing fasciitis. There could be the muscle involvement in necrotizing fasciitis. but it depends on the organism whether the muscles are involved or not. But subcutaneous tissues and the fascial destruction is the must in necrotizing fasciitis. According to the organisms involved, it has been classified into 4 types. Necrotizing fasciitis is mostly common with type 1 and type 2 in UK. Type 1 being most common, and it is caused by a mixture of obligate and facultative anaerobes, including bacteroids and peptostreptococcus. Whereas type 2 is common in 20 to 30% of cases, and usually it is caused by a beta hemolytic streptococcus alone or in combination with Staphylococcus aureus. Clinical features of necrotizing fasciitis. This patient could be presenting with an early stage or could be presenting late in the disease. If the patient is presenting early in the disease, we should be very well alert that on examination there will be nothing much, but the patient will be in severe pain. The pain would be out of proportion to the clinical findings, which will be associated with fever, malaise, or flu-like symptoms. On the late sign, the patient could be presenting with tense edema and the woody feel to skin. On palpation, there could be crepitus and surgical emphysema. And systemic, the patient could be presenting with hypotension and septic shock with other multi-organ dysfunctions. Investigation. Investigation of choice for necrotizing fasciitis is to take routine blood culture and blood gas. And X-ray and CT scan could play a role in some of the cases that could show air dissecting the fascial planes. This is one of the picture with the necrotizing fasciitis and X-ray taken from the same patient. Can anyone guess the pathology shown in the picture for which is suggestive of necrotizing fasciitis in this patient? Okay, so
maybe it's a bit of ear on the X-ray.
Yes, Tilak. So it's basically here. It's showing the air collected in the subcutaneous tissues.
Possibly the left-sided empyema was the reason. Maybe staphylococcal.
Yeah.
No, but on the X-ray, I think you can see surgical emphysema.
Yes. Yes. Okay. Thank you, guys. So moving on to the management of necrotizing fasciitis. NF is an potentially life-threatening and limb-threatening condition. So we must resuscitate this patient aggressively and plan to involve the surgical and ITU team early as possible. For the management aggressive resuscitation of this patient with IV crystalloids, starting off early antibiotics for this patient after sending the blood cultures. We should target the antibiotics for the possible organisms, including Streptococcus, Staphylococcus, gram-negative rods, and anaerobes. RCM guideline has suggested to start this patient on flucloxacillin, benzyl penicillin, metronidazole, clindamycin, and gentamicin all together. But we must consult to microbiologist on duty before starting the antibiotic, and we must involve the surgical team early for surgical debridement. So moving on to the last topic of discussion today, I have put on this picture. This patient is 5-year-old female. She is coming with fever and the rash as shown in the picture. She has been drowsy in the department. Can anyone thought of any probable diagnosis for this patient?
Coco,
Meningococemia?
Yes.
Meningococemia, I guess.
Yes. So this patient is this rash is typical of meningococemia. So this brings us to the discussion of meningococcal infection. The causative organism for meningococcal infection is Neisseria meningitis. The transmission is respiratory secretion. It is usually affect the normal and healthy children and adolescents. Clinical presentation of meningococcal infection, clinically it's fever, malaise, arthralgia, nausea, vomiting, photophobia, and there could be signs of meningism in case of meningitis. Cutaneous manifestation. It is one of the clearest and most important signs to recognize. The rash is typically blanching, and it may appear as, it is a non-blanching rash, and it may appear as the petechial rash or purpuric rash. As shown in the picture, when pressing the glass over the rash, it has not appeared. It is a typical non-blanching rash. We can see the involvement of the conjunctiva, and the rash is so widespread. It has involved the sole and the lower extremities. But we should be aware that this disease process can be advanced before the rash start to appear. The blanching rash may develop into non-blanching rash as the illness progresses. A rapidly evolving petechial or purpuric rash is a sign of very severe disease and is a risk factor for the fatal outcome. Investigation, we do routine bloods, urine analysis, blood culture. We must consider CSF analysis, and management is the empirical antibiotics. So thank you. My references are Oxford Handbook, Illustrated Synopsis of Dermatology, NICE Guideline, RCM Learning, and Rosen's Emergency Medicine. Thank you all.
Thank you, Dr. Prajwal. Could you please go back to the slide? Those criteria for TSS, 4 criteria you told.
Okay. Just a moment. Yes. Yes, is it Sambu?
Yes, thank you. Okay. Where did you get this from?
It was taken from Rosen's Emergency Medicine, 9th edition.
Okay, thank you. Thank you, Dr. Prajwal.
Okay, sure.
Yeah, I think, yeah, Prajwal, very good presentation. And especially, you know, the dermatological emergencies, which were, I will understand, you know, the classification of 2 types. One is immune modulated, and another one is causing by the bacteria. So that's what I could understand, that we could divide in 2 main categories: Stevens-Johnson syndrome and the necrotizing epidermal necrolysis is the immune mediated, and the other one is Carter-Skin syndrome is a bacterium moderated. Very good distinction in these 2 types of skin emergencies, and they are really emergencies. People, you know, deteriorated, you know, with the necrotizing fasciitis in minutes. You know, coming to the hospital, then, you know, bit of delay, half an hour delay, they end up going to the ITU if we want to act quickly. So dire emergencies, you know, I've dealt with quite a few of them. I think the other thing is skin is dermatology. I fancy to become a dermatologist. Can you believe me? It's so fascinating, so interesting. Then the people did not let me come in the dermatology, you know. So I think it's a people loss, not my loss, Patrick. So dermatology, oh God, it's so beautiful branch of medicine. I think, I don't know. I mean, we can't go back now, but if I'm born again, believe me, I will be a dermatologist. So beautiful branch of medicine. And the good thing, it doesn't involve so much investigation, so much hustle. It's just your memory and systematic approach to diagnose dermatological conditions. I think one figure in dermatology is very important. Prajwal was saying half a centimeter, but some people will say 1 centimeter. So this figure is very, very important in dermatology. So anything below half a centimeter is different, above a centimeter different. Morphology is very important in dermatology. So sometimes you divide in primary morphology and secondary if the superadded infection. Very important. Demarcation, very important in diagnosing. Similarly, distribution of the rash, configuration of the rash, and color. God, I mean, few things in dermatology. If you can put in a system, and the diagnosis will be not difficult at all. For instance, this meningococcal septicemia, the incidence of, the rash is not common in septicemia. When the rash is there, so, it's a very, very advanced stage. And especially young kids, they're not they're a bit jittery, not settled, in infant. And typically the parents say, oh God, his hand and feet of my kids are very cold, but otherwise it's a high temperature, So even that's a clue, so you should crack on the antibiotics. It's so much so important. If they come to the GP practice, they give intramuscular benzyl penicillin, then they send to the hospital. So putting an antibiotics in children in meningococcal septicemia is a really, really life-saving. And it's so wretched disease that, you can see on the television with the arm amputated and the leg amputated. They showed one little girl on television, is 4 leg amputee little girl, because she had a meningococcal septicemia. And you can imagine in the UK, where the NHS is very active and people pay a lot of money and hospitals are in every town and villages. So it can happen here. So not to talk about, Nepal or Punjab or India or, in some, Mozambique or Nigeria. No, I think, yeah, absolutely. So I think, you guys are very good people to spread this message across in desert countries. It's really devastating disease. Yeah, rash is a very, very fascinating subject, dermatology, and you need to know a few things how to diagnose. You have to be systematic, and the diagnosis is there. And as he said, it can be a primary sort of rash, or it can be a secondary to the systemic manifestation, rash as a toxic shock syndrome and this sort of stuff. Yeah. Thanks you, Prajwal. Yeah.
Thank you, Mr. Jain.
Thanks, Prajwal. I can't imagine Mr. J being a dermatologist, but it's okay.
Prakash, believe me, given I would go, because it's so nice specialty. God.
So coming back to your presentation, I think this is a very good example of good quality presentation. He has numbered his slides, referenced his contents, divided his presentation into different subsections. He was slow, not rushing through. I think it is a difficult topic in the sense we don't see very commonly everything. At the same time, I think you have structured it well. So well done on your presentation. I think this is what we want from our trainees, to improve the quality of presentation as you grow. The other thing what I learned is the multiple antibiotics for necrotizing facilities. I usually give 2 or 3, but there are 4 or 5 in your list. And this is from the new RCM guideline, is it? Where did you get this guideline?
Yes, from RCM.
So this was learning for me, and I'm pretty sure everybody has learned something. So the other thing that was good was there was something for everybody in your presentation. Well done, Prajwal. Very good.
Thank you, sir.
Well done, Prajwal, for your presentation. I just wanted to know, whilst you're preparing for this topic, in our system, which is the ward that would actually take? I know if someone has got a severe rash, like what we said with Stephen Johnson syndrome, epidermal lysis, as well as other severe rashes where they're most likely to go into renal failure, they might end up on ITU. But which is in South Yorkshire. Is it Rotherham where dermatology is spoken to when they're discussing some of these severe skin eruptions?
Patrick, the first case I discussed, it was seen in the Rashes, and this patient we had to call the dermatologist on call from Doncaster Royal Infirmary itself. We've spoken to, yes.
We've got an input from Doncaster. Okay.
So that is what I know. There is dermatologist on call available, but the medics are allowed to call if needed help, if they need.
The skin emergencies, dermatology, you remember, Patrick, when we were little kids studying, so there was no separate dermatology. It used to be looked after by medical people. So dermatology is an offshoot of medicine, so it used to be lumped under general medicine. And still, there's some hospital like Hope Hospital, Salford Royal Hospital. They have got a very well-established dermatology department, and they have got, University Hospital. So they've got their separate ward and beds. And I think the other hospital in District General Hospital, they have treatment rooms. And in some hospital, they've got few beds in the treatment room. For instance, the people with the eczema, kids, and eczema is a nasty condition. They need a special dressing, and similarly, as I understand, bad set of psoriasis. So and the bullous disease, pemphigoid. So these set of special things, they call them back and treat, and they've got a few beds like a short stay beds. But in most of the general hospitals, they don't hold the separate beds. So they come under the medicine because acute treatment done by the acute medical people, and then next day, ward round, they request the dermatology, and the dermatology come and they put their specialized input.
Okay, yeah, thanks for that.
Patrick, my experience with dermatology emergencies in Spain was that, dermatologists, they never work during the night. Then they just during the day, normally when I do my specialty there, we can call the specialty and they come to see if it's the case like this, no? I mean, no, for urticaria, for things like this, no. But for the difficult one, we call, but during the night, there are no dermatological or dermatologists on call. Then I think medicine, they must solve if we have any problems about that. I think, I don't know here, because I never have big case in a dermatological case in England.
Oh yeah, because in Basset last time when I had exacerbation of psoriasis, the patient ended up being admitted under general medicine for, like what Mr. J is saying, for the acute admission, Well, the patient needed IV hydrocortisone and Piriton.
I don't know if it's possible to call them during the night, for example. We have the doubt now that we have all these antibiotics.
They're not on call. This is 9 to 5 job dermatology.
Yeah, 9 to 5,
But they are, for instance, Prajwal is saying 80 to 90% of the skin involved. So you can imagine if the burn is 80% burn on the skin, which is fatal. So, these people, rather than seeing dermatology straight away, they need to see ITU and supportive treatment and, hypothermia and fluid and antibiotics and steroid. So, they need a quite specialized set of critical care, really. The dermatology, for the fine diagnosis, they can be involved in the day. I mean, it doesn't matter whether people have got, when that sort of people are unwell. So what the fine diagnosis is Stephen Johnson or toxic shock syndrome or what? So they are really unwell. So you pour in whatever is available, what thing that will help really these unfortunate group of the patients.
Okay, so we'll stop.